issues at the moment with supply chains, but we are making good progress, so I shall keep you updated in terms of more of a precise launch date. And we have here a very interesting case. We're commencing with the patient's left ear, but however it's their right ear that is really, really interesting. They've got this clay type of earwax, it's matted. They have been using drops for a while now. That can sometimes be counterproductive, because when you've got an impaction such as this, earwax drops are, yes, of course it will soften the wax, but it's not going to remove the wax. And in fact, for this particular patient, the use of the drops exacerbated their symptoms, because the ear was so already blocked, it absorbed the drops and it just caused the wax to expand and create more of an occlusion, which created more of a block sensation, a bit more myalgia, and more reduced hearing. In addition, they have tinnitus and it exacerbated their tinnitus. So I've just put some fresh dose of some olive oil spray, and what that has done is just change the consistency. And you can see all those hairs there, they are matted, and the patient had been using some cotton buds. And whenever you've got matted earwax, it is a bit more tricky to remove, and that's because it's harder to get suction grip. And what I'm doing here, I'm just working around the edge, I'm just trying to loosen this adhered wax and keratin off the canal wall. You can see we're being really gentle here, just want to go up against the canal wall and slowly then move away. So I've mobilised the bottom of this wax plug. I'm now trying to detach it from the anterior canal wall, so this is the patient's left ear. And if you do stay tuned, with the right ear is really, really interesting. The patient has got a very probable Canal Cholesteatoma, and they are very rare, but I've just edited another procedure using the WAXscope, which I'm going to be uploading today, hopefully. So if you do follow, if you want to watch that one as well, you can visit the Hair Clinic YouTube channel, or visit the Hair Clinic Facebook page or Instagram page or a TikTok. I think it's on TikTok actually, it's you have to find it under the Wax Whisperer. But with that one, I used the WAXscope, and that patient also had a probable canal cholesteatoma. They're very rare, but that's 2 potential canal cholesteatoma in a day. You can see I've managed to remove that large wax plug. We've got great magnification there of this patient's left eardrum. That's the short process of the malleus, just the focus. You can see all the blood vessels. Just having a good inspection, that's nice and clear. So that's the left ear now. This is the patient's right ear. Now this right ear was slightly narrower. I put some olive oil spray immediately because the consistency was the same as their left ear. You can see that oil there, it's glossy in appearance. Just so you're aware, I'm using our 4.25mm specular here. That's going to be our standard size, I imagine. We have got a smaller speculum, which is a 3.5mm, and then we've got 2 larger ones. We've got a 5mm speculum for larger ears, and then 5.75, which would probably be more useful for mastoid cavities and large ear canals. So this side is a bit more difficult to remove. I'm having to just make this little movement just to detach the wax from the side of the ear canal. It is a lot more matted this side. The ear canal is a bit more narrower, and the core of this wax is a bit firmer. Now, you may already start to see at the bottom as I'm lifting this up, there's a bit of discharge underneath this plug of wax. You can see a bit of octaria, a bit of green discharge. It's a bit of an infection, and that will become more apparent in a moment as I remove this. Now what I've managed to get here, I've managed to obtain the suction grip, and I don't want to lose the suction grip. You can see I did momentarily lose it there, and I'm just going to re-establish the suction grip, and then I'm going to very, very slowly bring this wax plug forwards, and as I am, I'm having to manipulate this wax around the curvature of the ear canals for the first and second bend. So I'm bringing this forwards. entrance of the canal, a bit more narrow than the left end. Here I've got this suction grip and I don't want to let go of that now. So a good tip is just really hover over the wax. Don't try to be patient, slowly bring it away. I forgot to take an image of the plugs of earwax after the procedure, and they were extremely large. I just obviously there's more focus on this now. So you can see all this yellow, greeny discharge here. The eardrum is visible. I'm just focusing more on this discharge. You can see there's a bit of wax in the distance as well, so we will remove that. But I want to see what's underneath this. It could just be, as I said, it could just be a layer of dead skin that's slightly infected, and underneath that it's all healthy. But we don't know, and it's really important that, if possible, you try and remove. So you can see underneath that, the discharge and the outer ear, you can start seeing a thick layer of epithelial skin. And beneath this, we've got a very large ulceration. It's very medial, and essentially they've got a large widened area of exposed and erosed bone. And to me, obviously it'll need to be diagnosed by an ENT specialist and probably go under a CT scan, but I do think that is very likely to be canal cholesteatoma. So what I'm just doing, I'm just getting this wax off the eardrum. I just want to clear that out of the way so I can just refocus back onto this canal cholesteatoma. And again, if you continue to watch, I'm going to start cleaning this out and you'll see the exposed bone. So just a bit of keratin just near the entrance. I'm just going to change the focus. I just want to clear the way a bit really, and then so I can focus on that region. I am going to also show you a comparison video of the WAXscope examining that area of exposed bone. There is no competition in terms of view. Even when it comes to the ENT microscope and an endoscope, you just cannot compete with an endoscope because it offers this wide panoramic view. It's almost like you're inside the ear and you're looking around. So the WAXscope is not designed to compete with an endoscope in terms of a wide field of view. Instead, it's the next best alternative, I feel. I've got an ENT microscope in the clinic, and it's an operating microscope. It's a very good microscope, and yeah, it provides brilliant magnification. Similarly to the WAXscope, the view is a lot more narrow than an endoscope. That's because you're using a speculum. I've used head loops in the past. In fact, that's what inspired me to develop the WAXscope, the wireless endoscope, because with the head loops I really struggled to see more medially towards the inner third and the eardrum. In fact, I probably would really struggle to do this with the head loops that I had, at least anyway. And so an ENT microscope and an endoscope are the two gold standard methods, I feel, of wax removal, but an ENT microscope weighs a ton, it's very expensive, and it does take a high level of training like an endoscope to use. So the WAXscope, I feel, offers you a great, I would, compared to the microscope I've got, I would say in terms of wax removal, it's the equivalent, if not slightly better, I feel. And I'm trying to say all this without being biased. Of course, I've got commercial interest there. I developed the WAXscope, but if I'm being really objective, I really do feel that. I'm really confident in what we've achieved here. So you can see now, I'm clearing the way now. There's a bit of crusted, hardened keratin. There still is a bit around the edge, but we're beginning to see this dip in the ear canal, this erosion. You can see the bone there, so that's exposed bone. We're going to be really careful. When you've got exposed bone like this, it can be really uncomfortable for the patient to make contact. Now, I don't remove every little last speck, and two reasons. It's not always possible to do that. When you've got really hardened keratin, it's embedded, it's like stone, and that really will need to be seen by ENT, and sometimes that just needs to be treated surgically. They will need to go to a CT scan, no doubt, as well. But also, there was a stage during this procedure near the top part of that ridge that when I positioned the suction probe there, that bone was almost loose. I could compare it to a loose slab on your footpath, or a a loose roof tile. The bone actually was moving, and just there, just that top bit, I don't know if you saw that with the tip of the suction probe when I just touched the top part of the ear canal there. So you can see that ridge is where the ear canal should be, and it drops down, so you've got like a massive ditch there, and some hardened keratin within that, and this region I've just been careful about, because I could feel the bone actually move around. It was unstable. It's almost like a cliff edge here. So this shouldn't be there. That should all be bone, and on top of that should be a layer of skin. So we're looking really into the temporal bone here. There we are. I don't know if you just saw that. The skin layer on top did move, but I felt like the bone was very unstable there. So just be careful to avoid that area. Again there. So what are the causes of that in this particular patient? This is sort of a question the patient asked me. You can develop a canal cholesteatoma. If that is the case, it's not confirmed yet, but some patients have anatomical defect of the ear canal, where they've got a trench dip within the ear canal, and as the skin migrates off the eardrum towards the entrance of the ear canal, it can get trapped and collect within that anatomical defect of the ear canal, and that skin then gets infected, it forms a plug, and it can then infect it can expose the bone, the floor of the ear canal, temporal bone, and then the bone can get infected, and the infection can spread, and it's something that needs to be treated. It can be quite dangerous if left alone, so it can start affecting the jaw and move superiorly towards the brain. You see the eardrum there, it's nice and healthy itself. That's the exposed bone area. So there is some embedded keratin just there on the cliff side of it. But again, I don't want to go into that because it just felt a bit unstable. So we've given an referral. And here's the endoscope view. You can see, actually, that it's a lot wider, but the view is very similar to the WAXscope in that sense. You can see that. The erosion of the bone part of the ear canal.